Good morning. We have the pleasure of having, this is Dr. Olaf Agasti talking, and pediatric GI, and we have the pleasure of having this morning presenting a lecture on childhood obesity, childhood and adolescent obesity, Dr. Amanda Tiffany. She graduated from VCOM in Blacksburg, Virginia, from medical school, and she's going to discuss the problem and the large topic of pediatric obesity. It's my pleasure to introduce you to Dr. Tiffany. Thank you.
Thanks, Dr. Actually, Mike. So good morning, everyone. Thank you for that introduction, Dr. O. As you mentioned, I am one of the pediatric surgery residents. Residency is coming to a close very soon, and I'm actually thrilled to be staying on with Carilion and joining the Carilion Clinic Vetta office out in Belleville. So today I will be presenting on the topic that I feel as though we all experience on almost a daily basis. Childhood and adolescent obesity is a big topic, and it's an even bigger problem. I do not have any financial disclosures, nor do I have any relevant affiliations or relationships with any of the products that we're going to discuss today. And here we have, of course, our objectives for the day. I kept them pretty concise just to keep us on track. This is a huge topic, but we're going to focus mainly on the prevalence, the demographics, and the associated comorbidities, as well as then looking at the current management and treatment options and the indications there are for bariatric surgery in obese adolescents. So we're going to do something a little fun, which is one of the reasons why we wanted to get started this morning. If you'll pull out your phones or your laptops, you can go to kahoot.it, and it's going to prompt you to put in this game pin. And we've only got about 4 questions, so we won't spend too much time doing this, but it's just something to prime people for the conversation. So I'm going to exit out of this and show you the game pin is up here as well. It will ask you to put in a username, and for that, it will show up on the screen, so don't put anything that you don't want people to see. Those of you on the line, we're just getting hooked up to a little game that we're going to play, 4 questions. It's at Kahoot, Kahoot.it, and there's a game pin if you want to play along. It's 802-6624. We'll get started in just a minute once we get some more people logged in, and then we'll get going. We have a lot of material to cover, so just want to make sure we leave some time at the end for questions. In the room. You can also continue to join while we do it. You just won't see your name pop up. Oh, I like Sleepy. That's cute. All right, so we'll go ahead and get started. The questions will be up on the screen, and then you'll be prompted to answer the question based off of shapes that'll show up on your phone. So the first question is, how many children and adolescents are affected by obesity? The triangle is 10.7, the diamond is 11.7, the circle is 12.7 million, and the square is 13.7 million. You do get points for answering the fastest if you're correct. All right, good. All right, so 9 of you got that correct. It's 12.7 million, and we're going to talk about that in the talk. So Skeletor is leading. What is the definition of obesity for children and adolescents? Is it a BMI greater than or equal to 85%, a BMI that's 85 to 94%, BMI that's greater than or equal to 95%, or a BMI that's greater than or equal to 99%? Right, so the right answer is a BMI greater than or equal to 95%. A good spread there we'll talk about. Oh, so somebody got taken over. RM is now on the lead. Which of the following is an FDA pharmacotherapy that is approved for treatment of obesity? Orlistat, metformin, sibutramine, or patelistat? That's actually FDA approved for the treatment of obesity. The correct answer is orlistat. Very nice. See, we don't even have to talk about this. You guys are so good. All right. And then the last question is, what is the preferred emerging surgical intervention for adolescent obesity? Is it a Roux-en-Y gastric bypass, an adjustable gastric band, a duodenal switch, or a vertical sleeve gastrectomy? This is pretty recent, coming out more and more in the bariatric surgical literature. That's going to be the vertical sleeve gastrectomy. So we got a good split there. Perfect. All right, so that's just to get things primed. We'll talk about each one of those as we go. So getting started. So in order to really understand the magnitude of the problem that is childhood and adolescent obesity, we have to understand how many people are affected. On the left-hand side of the screen, you'll see there that I have the adult statistics, 36.5%. From the years of 2011 to 2014. That's not where we're going to spend our focus today. In looking at the 2011 to 2014 data that was collected by the CDC's National Center for Health Statistics, the prevalence of obesity remains relatively stable for childhood and adolescent statistics at 17%. It does affect 12.7 million children and adolescents, which is just a staggering number when you think about such a wide disease that's affecting so many patients in our population. In the data briefing itself that was done by the NCHS, they also evaluated the rates broken down into age, which you can see here. 2 to 5 years old, the rates have been decreasing, which is promising, and they had previously been reported as high as 13.9% back in 2003 to 2004, but now they're down to 8.9%. And then the 6 to 11-year-olds are about 17.5%. But then again, our 12 to 19-year-olds are still higher at 20.5%. So there's no statistical difference between the females and males when it comes to the data that they looked at in the 2011 to 2014 data between the rates of obesity. So it's split pretty evenly. The trends in obesity prevalence over the past 15 years do demonstrate that we've made some progress in halting the dramatic increase. However, we've not seen the dramatic decrease that we would prefer and is, of course, the desired outcome. But at least we can see that there is a minimal effect that we're having. So even if we feel like we're talking to a wall or giving the same speech over and over again, we are making a difference. If you look down here at the bottom of the screen, you can see that from 2003 to 2004 up through the most recent data that was reported from 2013 to 2014, the rate has gone from 17.1 to 17.2. And if you look at those first 3 years, from 1999 up through 2004, there was a dramatic increase by about 2 every year that the data was collected, but now we've been able to hold that really steady. So if that had continued to rise, we would be looking at rates or prevalence of obesity upwards of the high 20s. So this is really just for interesting facts. Of course, we know that obesity rankings can differ by state. I was very pleased to find that Virginia was not in the top 10, but it does rank 22nd with about 13% of our obese high school students, which was the data that was represented here. Most of the states are located in the southeast, which I think is something we experience from our West Virginia, our Kentucky, and our Tennessee border states as well. The only one that's kind of an outlier there would be Delaware. But thankfully, we're not in the top 10. So then we really move into, we know that childhood and adolescent obesity, the BMI is not specified with a specific cutoff as it is in adults. Obesity in children and adolescents is defined as that BMI that's greater than or equal to the 95th percentile. This is, of course, going to lead to the fact that you have the excess body weight and a deposition of adipose tissue. Now, the BMI is calculated in their weight that's measured in kilograms divided by their height in meters squared. And that is going to change in relation to their age and how they grow. So you can't say that one static number represents obesity, which is why we use our growth charts that we'll look at on the next chart, or on the next slide. The National Initiative for Children's Healthcare Quality focuses on proactive solutions, quality care, and healthy living practices. This was actually developed in 1999 to focus on improving care of multiple different diseases that affect children and adolescents, including things like asthma, ADHD, and other specific healthcare needs. But they did in, they did in 2007 decide to make and expand to encompass obesity as one of their prime targets. So their website actually includes a lot of really important evidence-based practices to lower the obesity rates, as well as descriptions and ongoing projects for families and patients. So here we have our BMI charts. On the left, you'll see for girls from 2 to 20, and on the right is the boys chart. So again, it differs based off of your age, which is across the bottom axis, and then the BMI is on the y-axis. If you're in that green area, anywhere from the 5th to the 85th, you're in that normal range, which is where we like to see our patients. If you get into that yellow zone, you're kind of in the warning between 85th to 95th, and if you're over that, you're obese. And that is something that we need to be discussing. We can't really allow for that to be something that goes undiscussed at well checks at each visit. So the demographics, race does appear to impact the prevalence, with Hispanics having the highest rate of obesity prevalence at 21.9%. That's been followed by non-Hispanic blacks at 19.5%, and then non-Hispanic whites are followed shortly thereafter at 14.7%. Now, the lowest prevalence I thought was interesting were non-Hispanic Asians, and they have a lowest prevalence of 8.6%. I think a lot of that is cultural and their activity level as well. Young low-income children that are part of the Women's Infant and Children Program, also known as WIC in Virginia, do have a higher obesity prevalence. The most recent data in 2014 demonstrated that that was about 20%, so slightly higher than the national average. And that's all based off of socioeconomics, and we'll touch on that a little bit later. But these children in the households do tend to have higher obesity prevalence rates. And that bottom bullet there is really shocking to me, but it was well demonstrated throughout several articles that I looked at. Obese children, of course, do tend to turn into obese adolescents, and obese adolescents become obese adults, numbers as high as about 80%. So if you have an obese adolescent, about 80% of those will go on to be obese adults. So this is something that we really need to get in on the ground floor and start having an impact on. So when we look at obesity, right, at its most basic explanation, this is just a result of chronic caloric imbalance. The calories that are being consumed are greater than the calories that are being expended per day, and I would say on most days I probably am in that category as well. But the cause of this imbalance is multifactorial. It has certainly been associated with risk factors that are contributed to many continued problems, including family history of obesity poses a significant risk and is actually the strongest influence on obesity rates and prevalence in children and adolescents. If you have a parental unit that is obese, if you have two, then you are about 80% more likely to be obese than your counterparts who have two parents who are of normal weight, and only about less than 10% of those will go on to be obese. The other things to consider include their environment with their culture. Families today, like we all know, are just getting busier and busier, and that does make eating out a more viable option, but that leads to lower nutritional content foods and higher calorie content that are often associated with having an associated large sugary beverage next to it, or topped off with ice cream at your local favorite spot. So we have to continue to look at obesity as a family unit problem and not just an individual, because really if we can identify parents who are going to be at risk for having overweight children, then that's going to be provide us with the opportunity to provide more education and information that can help them to hopefully succeed. Now, there are, because I put physiology on here, there are a number of circulating factors, cytokines, chemokines, that are all associated with signaling the body to store energy into adipocytes. But that's not really going to be where we focus our talk today, because I think no matter how many times you told that to a parent, that's not going to impact what they do. I think what's going to impact them is what we're going to talk about next, and that's the associated comorbidities. So this impact really is consequences and comorbidities of obesity that stretch everywhere from medical to psychosocial. Here I've listed several of them, of the numerous complications that occur, but we're so familiar with these, and this isn't an exhaustive list, of course. Children with higher BMIs are clearly documented to experience things like higher blood pressure, higher lipid profiles, and dyslipidemia, in addition to the development of insulin resistance, which we see frequently. And then the concurrent comorbidities, as shown here, then follow them into adulthood. Because as we talked about, 80% of them are going to go on to be obese adults, and if that's the case, then we're starting these comorbidities very early on. So I thought it was interesting that two of the most frequently talked about associations were with asthma and dental issues, which are not two of the ones that I tend to focus on or think of initially when I think about obesity. I certainly think about the development of type 2 diabetes, hypertension, and the development of metabolic syndrome, but those are also comorbidities to keep in mind. So diving down a little bit into these comorbidities, it does include the insulin resistance. So insulin resistance, you get the adipose deposition that occurs. That leads to inflammation. You then get extra oxidative stress that occurs, which then activates different transcription factors and leads to some more insulin resistance. You get outward signs of this, with the most common being the acanthosis nigricans that we can see. But insulin resistance isn't the only concern that we have. There are other endocrine abnormalities that can occur due to obesity or as a result of, which includes decreased linear growth, or increased linear growth, initially, which then leads to early growth plate closure, which can eventually lead to a decreased height overall. And also of the puberty alterations that occur in both males and females. It can delay the onset of puberty in boys, and obesity can have an earlier onset, puberty can have an earlier onset in females who are obese. And then looking at hypertension, the number that jumps out at me is that there's a risk increase for hypertension as an adult. There are 8.5% fold increase to have hypertension if they are obese as a child. And that is based off of significant data that's followed. Primary hypertension we know is uncommon in children, but as a secondary cause of obesity, hypertension is seen, and it's important to be followed. So many of us know what acanthosis nigricans looks like, but I thought in case people had not seen this or just needed a refresher to look at it, that velvety type rash that sometimes parents will think is just not clean can be present, and that's your insulin resistance there. Oftentimes we do see it on the backs of the neck or the fold on the front, but I thought the picture on the left there was nice to accent the axilla can also be involved. So dyslipidemia is concerning. Overweight and obese adolescents have a significant increase in their risk of cholesterol abnormalities. Again, from 1999, so data is a little old, but that holds true through what I've looked at in the most recent literature as well, is that they have a 2.5-fold increase in having a total cholesterol that's greater than 240, a 3-fold increase in having an LDL that's over 160, and then the HDL, which we want to be higher, they have about an 8-fold increase in having an HDL that's less than 35. So we know that these lipid levels are going to cause them to have dyslipidemia, and then the concern is that these lipid levels are going to continue to track with their age and progressively worsen into adulthood if they remain obese. And there is concerns for atherosclerosis developing early, and then are they doing damage now that they will no longer be able to reverse at some point as an adult. And that brings us nicely, dyslipidemia, into metabolic syndrome. So certainly this has been covered extensively, and really I thought it was important to put this up there because it touches on a lot of what we just talked about. So the criteria, you have to have 3 or more of the following: hypertension, hyperglycemia, low HDLs, hypertriglyceridemia, if you've checked that, and then an increasing waist circumference. So patients with obesity are going to end up meeting at least 3, if not every one of these criteria when they come to our offices. Cholelithiasis, I didn't list that on the initial slide, but I thought this was interesting to discuss. It's largely uncommon in children, but with the rise in obesity, the incidence of cholelithiasis is increasing as well. The range is really anywhere from 8 to 33%, depending on what data you're looking at for those who are obese, but they'll have an incidence of gallstones in children and adolescents who normally would not. Obese adolescent females do tend to be at a little bit higher risk, and I feel like we've seen that here in our own hospital where we've had multiple admissions of patients actually having cholelithiasis or developing cholecystitis based off of their obesity as a result of. So sleep problems, including obstructive sleep apnea, is significant comorbidity. This, again, isn't always one of the main focuses of my questioning for parents, but parents will often report multiple nighttime awakenings, their child or adolescent having restless sleep, excessive snoring at nighttime, or even witness apnea if they're a patient who is either in the room or if their parent, if they happen to fall asleep on the couch. This is all due to the excessive weight in adipose tissue, which results in kind of daytime sleepiness, decreased ability to concentrate, and can sometimes be misdiagnosed as like an ADHD or concentration problem. So the symptoms can manifest, and it's either due to that prolonged partial upper airway obstruction, they can have actual intermittent complete obstruction, and then their normal ventilation is completely disrupted. So if these patients go in and have actual sleep studies, they end up with some, if not all of these on their sleep study. And about 40% of obese children will demonstrate true central hypoventilation, and that's proposed to be due to a lack of appropriate response to their hypercarbia and hypoxemia, but that's still being debated among people. And then about 94% on self-report, children and adolescents with obesity will report that they have abnormal sleep patterns on self-report. So this is something to keep in mind because this can affect everything about their day, whether they're able to concentrate in class or to continue to do well at work or school. And then last, but certainly not least, I think we'd be remiss if we didn't discuss briefly just the impact that being overweight impacts a child and adolescent psychologically and socially. These are a number of the possible consequences, including poor body image, which could lead to eating disorders. We've all seen that. Low self-esteem and isolation, which can actually lead to worsening or new onset development of depression. Discrimination from their peers, which then leads to anxiety and or behavioral problems, whether that's acting out or reverting inward. And the list really does go on and on. So we can't ignore these comorbidities as well because they're just as significant as the physical manifestations. So this has to be part of our focus when we're seeing these patients in the office as well. So now I'm going to ask you guys, well, what's the solution? How do we fix this, right? That's the question. If we talk about treatment and management, we've talked about our demographics. We know that all the complications that are there, it's a massive problem. It's a worldwide problem. And really we've got to figure out what can we do to help. And this was one of the quotes I found. We have to change the way we live, the choices we make, and focus on both individual and community involvement. And I thought that sounds good, but how do we make that happen? So we touched briefly on the National Institute for Children's Health Quality. Like I mentioned, they launched the Childhood Obesity Action Network in 2006. This is a national level organization that has 40 healthcare organizations, over 600 at this point, health professionals that are gathering to share both knowledge and develop successful practices and innovations surrounding obesity specifically. Their first guide, their implementation guide, was launched in 2007, and it had really 4 steps, but mainly focusing on the first step being prevention, that second step being treatment, and then when you move into the third and fourth, you've got to combine those two to make sure that we're doing everything we can to prevent and treat. Now, this was released 10 years ago. They have not updated this particular recommendation, but there have been updates since, which we'll discuss. So step 1, right, prevention. At each individual well check between ages of 2 to 18, or if you see 2 to 24, you need to be evaluating their BMI for all patients. So it's no longer okay for that 2, 2.5, or 3-year-old to come in and say, oh yeah, they'll just continue to grow out of it. This is something we have to talk about early. They need a full set of vitals, including blood pressures, which sometimes can be difficult on our younger patients, our 2 and 3 and 4-year-olds. You can't always get a reliable blood pressure, but that is something that we need to be attempting at a minimum, and then if you have any further concerns, really making that a priority. Discussing the family history of first-degree relatives, anyone with obesity, siblings, again, that parental unit, and then really assess the diet and physical activity. I feel like most of us are doing this, but the other thing to consider is what are their habits? Excuse me, what are their attitudes toward physical activity or toward food? Is this, a family that uses food to make themselves feel better? Is this a family who doesn't necessarily know when they're going to get their next, snack or wick or whatnot, and then they're worried that they need to make sure that their child eats everything on their plate because they don't know when they'll get another one. So you really need to be asking those questions, and not in a judgmental way, not in a prying manner, not because I just want to know, but because it's really important for your child's health. And if we put it in that scope, I think for parents, then this really doesn't come across as me just being nosy. And then, of course, we're all doing a physical exam to look for any of those outward signs. So they include preventative labs in this step 1. If the patient's overweight with a BMI between 85 to 94%, but they don't have any of those other risk factors, then you can get a lipid profile, which we're doing in our 10 to 12-year-olds anyway. If they're over 10 but have risk factors and are in that overweight category, then you expand your lab work just a little bit to include an AST, an ALT, and a glucose. And then patients who are obese are treated the same, because essentially your patients who are greater than 10 years old with risk factors, you're treating those even though they're in the overweight category, but if they were in the obese category. So when we talk about the main focus being prevention, interventions, we need to provide evidence-based messages and medicine to parents. Of course, we all are very familiar with our 5210, talking about 5 servings of fruits and vegetables, no more than 2 hours of screen time in a day, 1 hour of physical activity, and then 0 sweetened beverages, which I don't think happens in anybody's household. But we have to ensure that we're emphasizing understanding to parents and then providing advice and choices that are actually achievable for them. If you set an expectation of going from doing absolutely nothing to an hour of activity a day, every one of them will fail. So you have to give achievable goals for the family to meet. And then when you do get that apprehension from a mom or a dad or a teenager, they say, oh, I can't do that, then you have to elicit explanation and alternative actions from them. Get an idea of, okay, well, you can't run outside for an hour. Okay, well, can you play basketball for 30 minutes? And if that's their desired activity, that's still physical. That's exactly what we want. So you have to make it personal. There was a study in 2014 that actually evaluated 357 adolescents aged 14 to 18. And they talked about passive just discussion of obesity and healthy habits versus motivational interviewing with just the adolescent, and then motivational interviewing with a parent. And of course, which do you suspect did the best? Motivational interviewing on obesity with a parental figure present was more effective in getting the message across, as well as getting action from the families at home. So passive information in the waiting room, passive information in handouts that we give them, that all works. But we have to be doing a really important job in focusing on good information for parents and really making them a role model. We have to be able to change, again, that whole family dynamic, and they have to be ready to change. That's all of our, come alongside them and talk to them and figure out where they are in this process. Now, step 2 is treatment. So this is any patient who is overweight with risk factors or obese. And I'm going to show you the breakdown of this because it can get a little confusing. But during this step, again, you have to stay patient-centered. You have to use those motivational interviewing tools because that's going to be important for them. But at this point, you're increasing the number of visits, both with primary care and then potentially introducing new visits with a health professional, either a trained dietitian or a trained nutritionist, someone who does weight management on a daily basis. We're looking here for really lifestyle adjustment. And this should happen for at least 3 to 6 months. And you're looking for weight maintenance so that their weight just stays the same, or weight loss, depending on their BMI, which is on the next slide. If there's no improvement in that initial 3 to 6 months of intervention, then you add another step, and we'll talk about those. There was a New Zealand study in 2015 that evaluated 206 overweight, obese adults and children, and they compared what they considered usual care, which is your normal well check visits and then a follow-up 6 months later, versus their tailored program where they had a single multidisciplinary session with a group of specialists and then established specific goals for the families and met monthly with a mentor for a year. So that seems like a lot of intervention, and it is. But they also demonstrated that they had significantly lower BMIs in the children with tailored packages. Now, they didn't specify the number on that specific in New Zealand study in 2015, but a recent analysis done by Dr. Vetta in 2016 did demonstrate that, yes, we can see some improvement when it comes to the motivational interviewing and the lifestyle adjustment, but that for those with severe obesity, that this may not be enough, so we have to have other things that we can do. So this was the Childhood Obesity Action Network that was released in 2007. It does have the staged increase depending on the BMI in response to treatment. You've got on the right your stages, which we've talked about, the prevention, the structured weight management, and then on into our comprehensive multidisciplinary interventions in tertiary care facilities. On table 4, you've got a staged approach to their obesity treatment, and this is what I was talking about. So it's broken down into ages and then broken down into BMIs that are overweight but no risk factors, and those just get prevention and counseling. BMIs that are in that overweight but they have risk factors, and you start in stages 1 and 2 and then move up from there based on, again, that 3 to 6 months if you see no improvement, and so on and so forth, all the way up to a BMI greater than or equal to 99th percentile. And then in table 5, you can see the weight loss targets. Again, most of these, if you look at them, if they're in the overweight category but have no risk factors, you're looking to just maintain their weight velocity, let their linear growth increase, and then hopefully be able to maintain their weight. If you have a BMI that's in the overweight category but they do have risk factors, then you want to be able to decrease that weight velocity or, again, maintain the weight. If those things aren't occurring, then every time after that 3 to 6 months of intervention, you would step up to that next stage in table 4 in order to be able to hopefully get either weight maintenance or weight loss. And as you can see, as you get into the actual overweight, into the obese and extremely obese and the greater than 99%, you're really looking for gradual weight loss of up to about 1 pound a month if the BMI is very high, or a weight loss in your older children, 6 to 11 and 12 to 18, of about 2 pounds per week. So again, if you're in the lower risk or if you're in just the overweight categories, then you're just looking for maintenance. But once you hit the obese, you're looking for definite change in weight loss. The, excuse me, the stage 4 with the tertiary care intervention could include everything as far as even immersion therapies, meaning they actually go somewhere and are there for an extended period of time. There aren't many of those available, but they do exist in certain places. So what steps can we take to tell our families to do? At home, we need to be promoting physical activity. Again, that 1 hour of moderate activity a day, and it doesn't all have to be at the same time. It doesn't all have to be one activity, and it should really be focused on a family unit. We need to encourage the participation of the entire family and then looking at healthy eating habits, making sure portions are under control, that there's smaller, frequent meals throughout the day versus sitting down and filling your plate with food and then eating everything on it. Because in my house, you grew up, and if you put it on your plate, you ate it. That was the rule. Like, your plate needed to be clean before you got up from the table. But if we can do a better job of really having people understand what a portion is, then you're able to make an impact in just that small amount of choice making there. And then having healthy meals, which I think leads us well into, well, what can we do at schools? We can't really do much other than lobby for our legislation to make sure that they are, I know, it's frustrating because it is so hard. We don't feel like we're in control there, but what we can do is advocate for our patients and advocate for the parents as well. It should be a safe and supportive environment to help support the positive changes that are happening at home. And mandatory PE would be nice. I think most of us need a time in the day where we could have a mandatory time where we could all go have some type of physical activity as well. That would be ideal, and it's just part of our nation's work ethic. And if you compare us to the rest of the world, it's different. And then healthy lunches and snacks. So there have been a lot of good movement in schools for healthy meals. Some of that may change depending on what parts of the legislation are adjusted. But it was estimated that up to about 50% of a child's calories can be consumed while at school. That's half their day. Half of what they need is coming from whatever they're getting at school. So even if they're making wonderful adjustments at home, they may be seeing no effect because of what they're being offered while they're at school for 6 and 8 hours. So most of this we've touched on. Patients and parents need that multifaceted approach. Education, motivation, diet modification, and role models being important, both as the physician, the dietitian, nutritionist, specialists who become involved, but mainly it's their unit at home. It's their family unit. And this leads us into the bottom two, which is medicine and surgery. So there's really an inability to achieve desired weight loss, or if there's development of comorbidities despite their efforts, then you can consider pharmacotherapy. The treatments really should only come into play once 3 to 6 months of diet modification and behavior modification have happened. And the medications are not going to be beneficial if used alone. So families really have to understand that the medication is used in conjunction with their behavior, their diet, and their activity modifications. If you stop doing all of those things and start pharmacotherapy, the likelihood is you're going to see no result as well. So the complications, the risk of complications is amplified by an increasing BMI, and so as that BMI increases, we've tried to lose the weight, there isn't any assistance, then we can move on from there to the pharmacotherapy. So there are multiple categories, and in looking at it, the appetite suppressants with primary adrenergic effects were a lot, most of these studies were completed in adults, and there were a few small pediatric treatment trials. None of them showed that these medications were safe or efficacious in childhood and pediatric patients. So appetite suppressants with primary adrenergic is not recommended at all. Appetite suppressants that have primary serotonergic effects, there aren't any approved by the FDA, but SSRIs are intermittently used off-label as almost having a beneficial side effect of a little bit of weight loss and a little bit of appetite suppressant. So that would be an off-label use and is only helpful if there's a presence of anxiety. There have not been significant pediatric studies to look at the use of SSRIs alone in weight loss without the setting of anxiety. The appetite suppressants with non-selective inhibition of both serotonin and norepinephrine is sibutramine, so that showed up in our question. And there was a modest effect on BMI and total weight loss. They actually had a BMI that was reduced by 2.9 kilograms per meter squared from an overall standpoint of their BMIs that were starting in the upper, in this particular study was about, their BMI was 40 at the initiation of the study, and then it came down by 2.9. But the problem was that there was always concern with sibutramine about cardiovascular risk factors. So actually in September of 2010, there was a SCOUT trial. It was the sibutramine cardiovascular outcomes trial, which was a multinational randomized placebo-controlled, and it was actually conducted in 16 different countries. Had a mean age of duration of about 3.5 years, so a prolonged study, that looked at the clinical outcomes in subjects and looking for cardiovascular events. Now, a lot of this data did not come from pediatrics because there wasn't a lot of patients being treated with the specific medication. So some of this data is pediatric and some of it is adult-related. But what they extrapolated was that there were rates of cardiovascular events in the primary outcome was 11.4% when using sibutramine and only 10% when using placebo. So the cardiovascular risk was increased significantly on sibutramine, which was then felt by the FDA to no longer be safe for the use in children, and they actually in 2010 requested that it be withdrawn from the market, and so it's no longer available. The one medication, because we're going to move in now into the one that is FDA approved that we're not going to cover today is really metformin, and the reason we're not going to discuss that too deeply today is it's only been proven to have a positive impact on patients who have associated insulin resistance. It does show a moderate decrease in their overall total weight loss and BMI, but in patients who do not exhibit insulin resistance, there's no current data that demonstrates that it actually benefits them to use that without the setting of insulin resistance. So the answer to our question earlier was orlistat. Orlistat is the only medication that holds an FDA approval to treat obesity among adolescents. It is, the mechanism of action is that it inhibits gastrointestinal and pancreatic lipase and then reduces the absorption of about 30% of your ingested dietary fat. This was first approved by the FDA in 2003, and it's approved down to the age of 12. Most medications, when they're approved down to 16. Orlistat was able to be approved down to the age of 12. So this does lead to decreased absorption of fat-soluble vitamins, meaning that daily supplementation with a multivitamin is necessary to avoid any vitamin deficiencies. But as you can expect, if you decrease your fat absorption, you're going to end up with some significant side effects. In the JAMA study in 2005 that was completed, they showed about 50% of patients had fatty stools, 29% would actually end up with oily spotting, 22% had abdominal pain, and about about 20% of them had fecal urgency. So you can guess that this wasn't a very popular drug with people. The trials, however, in JAMA 2005, that multi-center randomized double-blind study was completed, looked at 539 obese adolescents. They were randomized to either orlistat or placebo plus a mildly hypocaloric diet, both exercise and behavioral therapy. So again, all of those parts were still there. And the orlistat was given 3 times a day. It did demonstrate an overall decrease in their BMI, but only by 0.55 kilograms per meter squared. But when you look at this, there was an increase in the placebo group of about 3.5 kilograms. So on the left side is their BMI, and on the right is the weight. Weeks across the bottom, that's those 52 weeks for the year. The most significant effect of the orlistat was seen in the first 12 weeks. Those first 3 months, you see a significant decrease versus the placebo group. However, after that, there didn't seem to be as significant effect, and you note that the curves are very similar as they increase over those next 52 weeks. But when you do look at this being the mean change in kilograms, your orlistat group was above, so there was actually some weight gain, but the weight gain in the placebo group was almost 3 kilograms total for that year, so 3.14 in the year. There was a dropout rate of about 1/3 actually on both sides, the placebo and the orlistat. So again, this is something that they're continuing to look at. And they didn't demonstrate any significant improvement in lipid profiles or glucose, no change in their dyslipidemia or endocrine associations. And the concern was that the weight loss was associated with a greater fat loss, but that once they stopped taking the medication and reintroduced that fat into their diet, that they would quickly then regain the weight that they had already lost. So now that we've talked about the one FDA-approved medication, we'll move into, with the last few minutes that we have, into talking about bariatric surgery. The current position statement that was just released in 2015 by Pediatric Gastroenterology and Nutritionists states That's the consideration of bariatric surgery in, quote, carefully selected patients with a BMI that's greater than 35 kilograms per meter squared who have severe comorbidities, or those who have a BMI that's greater than 40 and milder comorbidities are potential candidates for bariatric surgery. Now, the patients that meet those criteria account for about 5% of the overall obese population. So this is a very, not a very small, but a smaller portion of the 17% that we talked about at the opening of this talk. It is somewhat still controversial for adolescents, of course, but the volume of adolescent weight loss surgery in the U.S. tripled between the late 1990s and the early 2000s. And then in Pediatrics 2014, Thomas Ng re-looked at that data and said that from 2002 to 2006, there was about 61.8 surgeries per year. But when you look at the data from 2007 to 2009, it had increased, almost doubled, to 113.3 surgeries per year that are happening at these bariatric surgery centers. So this is certainly becoming something that is more, more available. The rationale for bariatric surgery in adolescents, again, is that persistence of a pediatric obesity into adulthood. We know that that extreme obesity is having a BMI. And the BMIs vary depending on whether you're looking at the American Bariatric Surgery versus the Pediatric Gastroenterology versus the Endocrinology. Each of the BMIs are slightly different, and then plus minus comorbidities. But overall, we understand that extreme obesity is going to follow them into adulthood, and that the overall prevention and counseling and weight loss, in addition to pharmacotherapy, isn't going to be enough to make an impact for them. Adolescents then proceed to have the adult diseases much earlier on. That increases both their morbidity and their mortality. They have an increase in obesity-related health care costs. There were some interesting data points that commented that by the year of 2020, that half of our costs will be due to comorbidities from obesity. I don't know that we're still on track for that, but that was published. There's a limited efficiency of, again, that behavioral and pharmacological approaches for severely obese patients, and surgical weight loss can really ameliorate or completely resolve a lot of the obesity-related comorbidities, and it is a durable way to have consistent weight loss. So bariatric surgery, there are criteria that they have to meet, and there are specific recommendations. These recommendations, again, depend. These are the ones that Thomas Ng had initially used in 2004. They did this release in 2015, another recommendation, and these are not, these are specific to each individual center. So each center may have a slightly different criteria that the patients have to meet. They do have to have failed at least 6 months of organized weight management as per the pediatrician, and then involvement of a multidisciplinary team. They have to be at or near their physiologic maturity. I'll talk about that on the next slide. They actually need to be able to commit to both a comprehensive medical and psychological evaluation both before and after surgery. Interestingly enough, I didn't understand why this was here initially, but avoid pregnancy at least 1 year after surgery. So in adolescent females, their fertility increases after weight loss surgery. And because of that, they have a higher risk of getting pregnant within the first year. It does pose risk from a surgical standpoint, and so oftentimes contraception is discussed during these meetings. You need to be capable and willing to adhere to the nutritional guidelines, provide informed assent, because again, there would still be their parents would be performing, they're providing the consent, but as an adolescent, the assent from them is important. And then demonstrating the capacity to make a decision, which sometimes when we think about teenagers, we're like, I don't know if they have the capacity to make any decisions. And have a supportive family environment that's really going to be there throughout this whole process. So when it comes to that timing, what considers them to be mature enough to have this specific procedure? So some will document sexual maturation between, or a Tanner staging of 3 to 4. Some will go as high as in meeting to Tanner stage 5. And then skeletally mature, most data will range on females from about 13 to 14, and on males about 15 to 16 are having obtained their mid-parental height. Now, most of the numbers you'll see in a few moments, these are going to average about 17 years old is who's having actual bariatric surgery. And then I think the bottom is interesting. Stages of cognitive development. having that formal operation to understand the possibilities and consequences of what might happen both during surgery, before surgery, and after. They do have to undergo psychological evaluations, structured interviews with adolescent psychologists, and then looking at, again, that cognitive maturity, if there's any evidence of depression, anxiety, significant or severe uncontrolled eating disorders, and then rating kind of their quality of life with their current weight and what that's going to look like after they have surgery. There aren't any complete or absolute contraindications that make a patient not a candidate in regards to these specifics, that these were relative on multiple of the recommendation lists, including substance abuse would make you would be a relative contraindication because that is not something that needs to be continued through surgery. Uncontrolled psychiatric disabilities, as we just talked about, or if they're unable or unwilling to continue with their medical and nutritional recommendations, or if they're going to be unwilling to follow up after, because these are not people who can just have the surgery and then drop off there. So the Longitudinal Assessment of Bariatric Surgery was a consortium that was put together by the National Institute of Diabetes and Digestive and Kidney Diseases. They were facilitating the acceleration of data collection and research. Once LABS was put together, they actually designed an ancillary study known as Teen Labs to look at just adolescent bariatric surgery patients. It was prospective, observational, and it was cohort designed of 242 adolescents who'd undergone bariatric surgery at the age of less than 19 years old. And again, this is one of the main authors is Thomas Ng, put out in JAMA of 2007. So what they found was, again, that mean age of participants of people who are actually or adolescents who are actually undergoing bariatric surgeries was about 17.1 years old, plus or minus a year and a half, had a median BMI of 50.5, and then in looking at the data, they broke down the procedures, and we're going to talk through those in just a second, but having a Row-and-Y gastric bypass was about 66%, the vertical sleeve gastrectomy was 28%, and then gastric banding was only 6% of the patients who'd undergone these procedures. 92% of them actually underwent their weight loss surgery and did so without any major complications. There were some minor complications, but the major complications and actually no mortality associated with any of these 242 adolescents occurred. There were a total of major and minor complications. In the Row-and-Y, it was about 26% of them would have some kind of minor complication, and then in the vascular sleeve, only about 16.5%. So this nicely demonstrates the kind of trend. The blue bar here is actually gastric bypass. The green is sleeve gastrectomy, and then the red is the laparoscopic adjustable band. You can kind of see that there's a swing. There's a trend that happens where there's less Row-and-Ys being performed and more gastric sleeves being performed, and we'll talk about why that is in just a second. Sorry about that. So this is a Row-and-Y gastric bypass. It dates all the way back to actually the 1980s for being used in adolescents, all the way back to 1960s and earlier for adults. But it's a restrictive and malabsorptive procedure. It can be performed laparoscopically. The stomach gets divided, and it creates a small pouch there at the proximal end of the esophagus, and the jejunal portion of the small intestine is then divided. The distal segment is attached to the newly created pouch, thus you bypass the distal stomach, the duodenum, part of the jejunum, and then that results in malabsorption. And then the proximal segment is then anastomosis to the distal portion of the jejunum. This clearly represents what was being more commonly done initially, but based off of the potential for them to develop micronutrient deficiencies, vitamin deficiencies, and long-term follow-up, there was a concern that maybe we could be able to move away from this malnutrients and into a different procedure that would be easier for patients to handle. We then also saw gastric banding as an option. It is efficacious, safe, has a lower risk for post-op vitamin deficiencies. However, it comes with its own set of possible problems as well. The laparoscopic adjustable band does place an inflatable restrictive band around just below the gastroesophageal junction. The band contains a balloon that goes down to that tubing that you see there to the access port, and it's filled with saline in order to tighten the band. There was here a significant need for reoperation that happened because of the complications, including slippage of the band or problems with the port itself, and anywhere between 8 to 25% of these patients actually had to have reoperation after having this specific procedure done. And as far as the literature is concerned, this is not FDA approved in patients less than 18 years of age, but it can be used off-label under an investigational device exemption from the FDA, so that is an option. And the Society of American Gastrointestinal and Endoscopic Surgeons in 2008 felt that this was going to be the next big thing after Rowan Wise, but as you'll see, we then got to vertical gastric sleeves. This is emerging as the procedure of choice here. You can see that there's the vertical separation of the stomach and excision of that greater curvature and fundus. It leaves the lesser curvature that has been stapled shut, creates a small sleeve, and you remove anywhere from 60 to 80% of the stomach on that greater curvature side. These were found to, again, have excellent weight reduction, reversal of the associated comorbidities, decreased short and long-term complications post-op in comparison to the Rowan Y procedures. So here, the overall outcomes, and this includes all three of the surgical interventions, includes a decrease in their mortality, a decrease in their morbidity, improvement in dyslipidemia in about 80% of patients, and then the hypertension and insulin resistance also improves. In some patients, the hypertension can completely resolve. And of course, once you get rid of some of that excess weight, their obstructive sleep apnea improves. And clearly, most of these patients are going to have a somewhat increase in their self-esteem and decrease in their depression and anxiety after, based off of their new self. So doesn't leave us with much time, but one of the takeaways for me from reading all of this information was that really prevention is key to stopping this epidemic. We have to start early so that the percent of people who really do need either pharmacotherapy or surgical therapy, the numbers are fewer and fewer. We've made some progress, but we haven't quite gotten to a place where we are seeing a decrease yet. So that's where we want to get. So I've got my references listed here with all of the studies included. And I want to say a big thank you to Dr. Olazagossi, Dr. Hart, and Dr. Collins, who provided me with a lot of the resources and just their time and energy, which I greatly appreciate. And I know we don't have much time, but yes, we could do a few questions, I suppose.
Maybe 1 or 2 minutes.
Okay.
I know I've seen sort of in the news and other things like that, there have been comments about research on the microbiome of those who are obese in comparison to those who aren't and how they're different.
Yeah.
Did you run in, and I don't know what's CNN and what's science out of that, to confess, but have you run into any data as either an investigational thing or as a potential therapeutic target?
I have not yet. In the research that I was doing, the microbiome has not really come up as significantly in the fact that they've not been able to do any evidence-based trials or randomized controlled trials on that just yet. Go ahead, Dr. O.
Yeah, there was some studies that had some specific information about using certain microbiomes, certain bacterial culture from people that were thin, and there was some dramatic effects on weight, but it's not clear what is the actual mechanism of it. Well, correct, but
yes.
Identified or using specific probiotics that are specific from these particular patients.
Right.
But yes, there is some promising, things to look in that regard. But the mechanism of the actual change is not clear. And one important factor in terms of management is portion size. How can we explain to parents how much we need to eat? And of course, parents has to be the coach of the child or adolescent. And we have charts in our office that will help in terms of hand portions, or what I usually use and tell the parent is if they eat 3 slices of pizza or 5, just cut it down to 2 or so by telling them how much portions you use for X amount of spaghetti, or so cut down in 1/3, and I explain to them in terms of bowls or cups, so they can relate to what to do, because that's what they're going to be using in the daily basis. And that might be very important. There are available charts, color charts for portions, hands portions. We have it in the office. Anybody is interested, please call, and our dietitian will be helpful in working on those. But we need to really give them very practical ways to really, in a day-to-day basis, know what to do with it. Thank you.
We're out of time, so you're off the hook for further questions. Thank you very much.
Good question.
Still on the line. Sorry, we didn't have time to unmute the phones, but if you have a question, you can always email me at outreach@CarelionClinic.org. Tiffany. With that, we're going to go ahead and disconnect the phone lines now.
Thank you all very much. Tune in next Thursday at 7:30.